Current psychotherapy models continue to follow the medical model. The medical model is that you identify a particular problem, understand its pathogenesis, and then you deliver ingredients that are specifically remedial to that disorder or problem. There's nothing incompatible with that view and the feedback-informed treatment model, because feedback-informed treatment is simply about assessing the client's A, engagement via the SRS, and B, outcome from the process. So whether you are a devotee of the medical approach, the medical view, or what has been referred to as the contextual model, which tends to accept both the medical model and highlight other variables in the client's life and environment that may contribute to their current condition, makes no difference in terms of applicability of FIT. Well, I hear two kinds of related questions in that particular question. And the first is about, is FIT a new paradigm? And I would say, not really. It is a Six Sigma type of intervention designed to improve quality and outcome, or at least you can tie it to other traditions aimed at improving quality and outcome in whatever element in the economy we're talking about, whether it's healthcare or perhaps even making automobiles. Second part of this question is how to facilitate a change of paradigms. And I would say, get ready for a long drive, because paradigms change slowly typically. And it's not really required to adopt FIT to change your paradigm. Instead, I'd point to something like implementation science that shows us how, in a step-by-step fashion, we can take good ideas, novel ideas, innovative ideas, and begin to help the system and individual practitioners adopt those ideas. And in terms of FIT, we follow the implementation science stages that we're going to explore first, that we're then going to install the necessary structures to support FIT, that then and only then do we begin initial implementation, which means that we're going to start using the measures. And then the last stage, which is full implementation, because many people get started using the tools, have gone through the three prior stages, but then they end up letting go of the process. In other words, they fail to sustain that implementation effort. So I would say, instead of thinking about changing people's minds or the system's paradigm, follow those basic steps, because you can help your staff make the changes necessary via FIT to deliver more effective and engaging treatment services. Well, for me, this is a bit of a straw person argument, juxtaposing training versus using FIT. What I can say is that FIT can help regardless of who is delivering the service. So if you're having peer support folks deliver some of the service, people with lived experiences, having feedback from clients really helps them shape their message so that it's more engaging, and having access to the client or consumer's experience of the progress or outcome can help us change up what we're doing in the event that it is not working. So I wouldn't say that it's either one or the other. I would say both could be additive to the outcome of care. And that fit could also, in a very useful and targeted way, show you where you might need more training. Perhaps it's in relating to people who are depressed, say, versus anxious, people who might be coming and who are trans versus a straight white person. All of these pieces of feedback can help us identify our shortcomings as a practitioner, and maybe then we go and we get some training on that particular topic. I think this is a fantastic question, and the answer is we don't really know. I think we have assumed that administering the ORS and the SRS is likely going to have a direct impact on the clients, both in terms of asking themselves and valuing their opinion about their experience of the treatment process, as opposed to feeling ashamed or leaving treatment because they don't feel like they're a good enough patient or client, or if the treatment isn't actually helping them, being willing to accept a subpar outcome instead of having their experience shared with the therapist and the helper being at least 50% responsible for changing things up in an attempt to help the treatment be a better fit and also more effective for the client. I would not say that the ORS and SRS are specific to psychotherapy. I would say that most of the writing that took place in the first decade of feedback-informed treatment, the examples used were drawn from psychotherapeutic practice. But since that time, the use of FIT has expanded to include mental health care in general, prescribers, both within mental health and within general pharmacy. We know, for example, from 2 studies by Jan Pringle, that using the ORS and SRS, pharmacists that is, improves compliance with a number of classes of different medication. There are, Charlotte Krogh out of Denmark has been using the measures in physical therapy. That is, when you have a strained arm or leg and need some work done, that in fact, the client's experience of both the connection with the provider of their care and the outcome that they get in terms of their well-being are often better predictors than the mechanical measures that are often used by physical therapists. So yes, at the same time, FIT is not applicable in all contexts. How could it really be? The key differentiators, it seems to me, are you willing to change if in fact the measures say that the client is not benefiting? And 2, does your service actually aim at changing the client's sense of well-being? If those 2 elements aren't present, then maybe FIT isn't really applicable in that context.